Hello, good afternoon, Frankfurt, and welcome to Kuala Lumpur. Thanks, Sheikh and host.
Good afternoon.
Good afternoon, Sheikh.
Good afternoon from from Frankfurt. I've got Gareth Morgan, Zaid Amin, John Thompson, and Bharat Dalvi on the stage, and a fair number of audience. I really realize your time is a bit late down there, and you're a bit tight as well. So go ahead.
All right, thanks, Sheikh. So I will, first of all, like to thank you and host and the rest for having us as part of the program for this year's CSI. And I will start with a talk on the IBS iron stent, followed by a brief video on a case which we did 2 weeks ago, and then a live demonstration of an ASD. So shall I start with a talk on the stent first? Can you put the slides on?
Yeah, I assumed IBS was irritable bowel syndrome, which is what I've got. But
all right. Okay.
Go ahead with the stent.
Right. Okay. So this is my disclosure slide. Right. I think we all realize that the literature on this bioresorbable stent in children and infants is very limited, partly because the developments of this has really been mainly in the coronary artery arena. And we know that this is an area which is very much unmet in terms of needs, especially when you look at these pictures here, an infant with severe RPS stenosis, and here another one with very small closing PDA supplying to a left primary artery in a situation of a tough absent primary valve. And we know that this kind of patients will require complex operations, and therefore it does make sense if a stent can be placed which dissolves, and then later we can allow more stenting and also probably a better surgical reconstruction. At the moment, what we have is the McMurray stent because the absorb from Abbott has been withdrawn. So what we have been using recently is a small study, pilot study on the iron resorbable stent or RBS from Shenzhen LifeTech Corporation. So as we know that in PDA, most of them are complex, and many of these patients in whom we stented the PDA is just a temporary measure whereby we will need to subject these patients for complex reconstruction surgery. And probably it does make sense that something that is resorbable is going to be beneficial because a BMS stent, which doesn't dissolve, has an impact on surgical repair, especially when we perform the surgery late more than a year or so. And this is a small series of surgical outcome in patients from Italy, whereby, although a small number, but 3 out of the 13 patients, they could not really remove the stent entirely. And this is shown also in our patient here as an example, whereby after stent about a year, we did the repair, and you can see that it's not really possible to remove all the metallic parts of it out of these patients. Nevertheless, the patient had a good surgical outcome. So what we have embarked on is to look at the clinical safety and efficacy for PDA stenting, although this is really a stent which is developed by LifeTech in Shenzhen for coronary arteries, which is coated with sirolimus. But we have requested that we want to look at this in neonates for PDA stenting. And basically, this has been many years in development, and what they have come out after many animals testing, that this stent is iron-based. They have managed to bring down the struts really thin, to 70 actually. But the stent, instead of just iron and PLLA with sirolimus for the vehicle for sirolimus, they have put a zinc layer on top of the iron so that it degrades only after 3 months when the zinc dissolves. So there had been a study which was just recently terminated in which centers in China and one in Malaysia took part in that. So I will go quickly to this. So just to compare the bench testing of the IBS stent as compared to science from Abbott, the strut is a lot thicker, I say significantly thinner than the science stent and most other cobalt chromium stents. In terms of radial strength, it seemed it was comparable from the bench testing, and also in terms of crossing profile, which means that we can use a 4 French sheath as compared to the other bioresorbable stent, which required a 5 French sheath. Right, and also I think in terms of what has been known from the animal studies is that we should see the iron dissolving after 12 months or up to 24 months. So with that, and also just briefly, what has been monitored from the animal studies is by using micro-CT, MRI, as well as OCT to see that at what stage that the iron starts to disintegrate or gets corroded, and this is what they have seen in animal studies, whereby by 13 months we should see some disintegration significantly of this iron stent. But what we have done is that from September, we started to recruit. The aim is to have 10 patients over a year. And what we are doing is basically to limit first, as a pilot study, to simple PDA morphology, which means that this kind of ductus, which is fairly straight, that comes off from the descending aorta, in which case quite often that the stenting procedure itself is fairly straightforward, but bear in mind that these are very sick infants, usually with PIVS or critical PS, which need balloon dilatation and thereby makes them quite sick. Therefore, we might say that it is a simple morphology, but the patients are not that simple in terms of hemodynamics and clinical condition. So what we were looking at is how they handle the visibility on X-rays, the acute results in the cath lab, as well as the post-procedure ICU results, as well as how does the stent performs after discharge from the hospital. And the exclusion is patients who weigh less than 2.5 kilograms and age more than 3 months. I will not go through this. So these are examples of a simple-looking PDA which has been stented. Right, so comparing a coronary as well to a PDA stent, what we are worried about is that when it comes to something which is going to be corrodable, biocorrodable over time, you don't have this kind of overhang in the coronary arteries, but when you do that in a PDA, there is bound to be some overhang on the MPA in the pulmonary arteries, maybe in the aorta. So because the concern here is that as the stent gets absorbed, parts of the stent might become lost in terms of integrity. It moves with the pulsations and parts of it might break off and migrate somewhere. Therefore, our aim is really not to have any overhang or very minimal overhang on the aortic end from the very start. So I'd just like to show our very first patient that we recruited about in September last year, and this is a patient with PIVS, very high RV pressure, mild transrespiratory regurg, but very high, very severe RV hypertension. That is the small right ventricle after balloon dilation. And this is looking at the PDA itself. Yes, this is a nice PDA to stent, to implant a stent, fairly straight looking with a fat belly, and no branch PA stenosis. This is crossing with the wire. Sorry. All right, and this is the angiogram once the wire has crossed the ductus into the main primary artery. See that nicely, yeah? And this is then we make sure we try to make sure that the stent will not really jut up into the aorta too much, which means no overhang in the aorta as much as possible. And this is post-inflation. You can see that the markers are here, right at the end of the ductus and the aortic end, maybe a bit more on the primary artery end. And this slide is showing the final results. This is showing the nice branch pulmonary arteries unobstructed. The PDA stent just enough into the aorta, and this is the immediate post-angiogram. And if you look at this, you can see that the visibility is not as good, maybe 50% of what you normally see in normal BMS, but enough for us to have a successful implantation without much problem. And this is at 3 months, reasonable shunt, but at 6 months, there is barely any flow across, but by this time, the patient is well grown and she needed surgery for RVOT reconstruction, and therefore the stent was removed, and this was subjected to histopath as well as, sorry, we missed that. Subjected to pathology studies, and all, but this was clamped by legal clips at the time of surgery, and therefore you can see a lot of fractures. But what we notice is that at 6 months, that the absorption was still below 10%. Right, this is just to show that in some patients with very long ductus, the stent might want to jut out a bit. Therefore, we try to make it really fitting into the aortic end of the ductus, and we missed by a few millimeters. So we top it up with the cobalt chromium stent so that it doesn't jut out with a absorbable part, and therefore you can see that in terms of visibility, it is not as good as the cobalt chromium, but enough, and that part is where the overlap of 4 millimeters between the cobalt chromium and the IBS stent. This is another example, the third patient that we did. This is the echo at the time of presentation, and this is 6 months after. The patient is now very well. There's no more tricuspid regurgitation. Nice RV, patient is pink, and therefore there's really no need for the stent to be patent anymore. So, but at clinic, we brought him to the cath lab for fluoroscopy, and we can see that if you notice here the arrows showing the dots, the markers at either end, this is the aortic end, but you can see the pulmonary artery end is now a small piece has migrated to the right pulmonary artery lower branch. But the patient is nevertheless well, and therefore this really brought, again, our concern that if we have the stent too much in the aorta, if this breaks off, it can cause some major problems. But if it is in the pulmonary artery, as in this case, we did in a way anticipate this, but this had no consequence, but probably we need to confirm that later with an angiogram. Right, so this is briefly our results for 9 patients up to July from September, and all of them except one case is really a case of cases of either pulmonary arterial intact septum or critical pulmonary stenosis, and 4 has reached about 6 months follow-up, with one patient who who died after being well for 1 month at home, but presented with quite very symptoms which might suggest an infection followed, culminated with probably thrombosis. So that is really something which we felt very, very bad about. One of the complications, all the procedures were successful, there was no major complications, but one in the ICU had prolonged overcirculation, and this might have caused the NEC, and this patient had surgery but did very well at the end of it, and now is currently almost close to 6 months follow-up. So all were discharged well, but there was one mortality, as we alluded to earlier. So 3 patients, more than 6 months follow-up. But what we noted is that all 3 had a good outcome. But in terms of PDA patency, I think by this time, these 3 patients all had very, very little flow through the shunt, through the PDA stent. But by this time, the stent patency was not really crucial to the patient's outcome. So in conclusion, this is just very early results, but what we have found out is that the acute and early post-procedure results in the ICU, in-hospital results are good. We had no major problems, although the patients were very sick. And in terms of how easy it is to implant, it is very similar to BMS stent. But in terms of X-ray visibility, it is about 50% of what we find in cobalt chromium stents, but enough to have a successful implantation. But however, these are patients with very simple morphology. 6 months is the time when we need to start worrying, because this is when the flow starts to become reduced, and therefore, but this is also the time when the patients either no longer needs them to be patent, or the patients will need to be subjected to another form of operation, either Glenn shunt or reconstruction of the after tract. So I suppose a large multi-center study is desirable, but I think in the longer term, what is important is that perhaps the major application of such stents, not just the IBS, but any other bioabsorbable stent in the PDA, is that most of the PDAs that we deal with are complex, and therefore we will need to test to see whether this stent is also applicable in such clinical situations. So with that, I would like to thank you for this talk.
Anthony, thank you very much for that very informative talk. Now, what do you want to do? Do you want to show a case or what?
We have a live case, which is an ASD in an elderly patient who had Watchman implanted a week ago in the LA occluded, because she also has chronic atrial fibrillation, and she is 65 years old. But I have a recorded tape on the IBS stent. If you want to see that, that was about 8 minutes. So what do you all prefer? You want to go straight to the live case or to the recorded tape to the recorded case.
If
Sure.
you can do the recorded case very quickly, then straight for live case because we've got Frankfurt waiting.
Okay, just let us know. I have 8 minutes of the recorded case, but you can cut short if you like. Then we go straight to our live case.
So do you want to start recorded now?
Okay, can we have it rolling? Yeah.
We
Go for
have
it.
a small infant, is a 12 days old baby who has tricuspid atresia and a very restrictive PDA, and she is on prostaglandin, weighing 3 kilograms. And what we plan to do today is to implant a new stent in the PDA. It is called an IBS or iron-based stent, and it is meant to be a bioresorbable stent. And we hope that by implanting this stent, when the patient comes back later for the surgical repair, there will not be as much challenges in removing the stent, and if there is a need for reconstruction of the pulmonary arteries. So my colleagues here today are Dr. Hisham, Dr. Bokrin, and Dr. Khalil from Afghanistan. So what we have done so far is to put in 2 sheaths into the right femoral artery and the right femoral vein. You can see here that the hubs of these 4 French sheaths are both pink in color, but at the top of the hub on the femoral artery is white, and this indicates that although the external diameter of the sheath is 4 French, but the internal diameter, it can take 5 French catheters. So by doing this, if we need to upgrade, for example, that we need to use a 5 French catheter, it is possible. Or in the case where you are implanting a stent, we might want to use a 5 French JR guiding catheter for this kind of PDA. So what we plan to do is to use this called the 4 French 5-on-4 slender sheath from Terumo, which is 4 in terms of external diameter and 5 in terms of the size of catheters that it can take. So what we plan to do now is to do an angiogram to see how the PDA looks like, how it comes off from the aorta, and do some measurements and see whether this is the right kind of PDA in which we intend to implant this stent. Okay. Right, this is a fairly long PDA, but it comes off from the descending aorta, which means that it is the right kind of PDA in which we can approach this through the femoral artery. So what we are going to do is that I'm going to insert this 4 French diagnostic JR catheter into this slender sheath and then try to get to the mouth of the PDA. Okay, you got the wire, Hisham? Okay, now I have this tip of this JR catheter in the mouth of the PDA, and I'm going to do another angiogram here, right inside the PDA. Don't give the, okay? Okay, sini. Oops, okay, very good. That flip out a bit into the aorta, but I think we can see how the PDA looks like. Yeah, it is fairly long PDA, but nevertheless comes off horizontally off the descending aorta. So what I'm going to do now is to cross this PDA with the BMW wire. So Hisham is going to help me with that. Can you focus on this, what Hisham is doing? Okay, Hisham? Okay. You can probably use just the BM wire. Okay. All right. Okay. All right. So I'm going to remove this JR catheter now and replace it with a guide catheter so that we can implant the stent. Okay. Sham, hold the wires. All right. Okay. Now Hisham is going to pass these 2 wires over the JR guide catheter. So this has a green tip. So this is a French JR guide which goes through this slender 5-on-4. Okay, right. Now I'm going to insert this JR guide into this 4 French slender. There it goes. So we go back to aleocranial. And go on back up, huh? Okay, we've done the angiogram. Now it's time to put in the stent. As you can see that this PDA is fairly straight, and in terms of its length, it measures about 12 millimeters from the lateral angulation. And towards where it connects to the primary artery, it is probably a bit tortuous and small and restrictive. And that is why this patient was prostate independent. So what we're going to do is that we're going to implant a 15 millimeter long, 4 millimeter diameter IBS stent. And Dr. Hisham is going to load this stent onto the wire. Normally, we tend to put the stent onto the stronger choice PT wire, which is the light blue in color. But here, I think because the wire position is much better with the BMW, which is right in the right ventricle, and therefore we're going to use the BMW wire whereby we want to deliver the stent onto. Okay, so let's get this stent onto the BMW wire, which is the green colored wire. So we need to remind everyone that before we inflate the stent, we have to remove the other wire, otherwise it's going to be trapped between the stent and the wall of the ductus. Right, we have removed the second wire, which is the transmitter wire, just leaving the BMW wire there for the stent delivery. Okay, start. Okay, Sham, let's move the stent across the PDA. Now it is sitting at the tip of this guide catheter. So Hisham is pushing it gently to cross the PDA. And I think by the time the marker distally is on the trachea, then we can start uncovering the stent. So let's uncover that, Hisham. I'm going to uncover the stent now. Then we do angiogram. Okay, so I think now the tip of this guide catheter is in the aorta. Let's do an angiogram. We're probably a bit too distal here. Okay, wait, Hisham, wait. Let's see. AP. Distal marker is in the main primary artery now. The distal marker is midway in the air column, which I think is fine. Because what the idea here is not really to have the stent jutting out into the aorta. So I am quite happy with this position of the stent. What do you think, Sham? All right, shall we inflate now?
All right.
Are you happy, Sham? Slow inflation.
Yep. 2, 4,
You don't let it jump.
6, 8 nominal.
Go 12.
1, 2, max 1, 6.
Okay, stop. Okay, let's deflate now. Well, that is the end of the procedure. We have now removed everything out of this patient except for the two vascular sheaths. That was a fairly, what we would call a straightforward PDA implantation, stent implantation, because the nature of the PDA is such that the anatomy is fairly straight and comes off from the descending aorta, very well suited for this kind of technique. Well, the patient's saturation improved from about 70s when the prostate was about 3 nanograms. Now it is about 88, 90. So I think it might look that the stent is a bit too big now, but this is a baby who's growing. So in a few days, in a few weeks, I'm sure the sets are going to drop some more, and then the PDA stent will be just nice for the baby for the next few months, maybe 6 months to 9 months before she goes for the first stage gland operation and Fontan operation. So with that, I would like to thank everyone involved in this room today for being with us and helping with this case. Thank you.
Mansi, thank you for that. Are you ready for your live case? Shall we go straight to that, or do you want to say anything else?
No, I think we're okay.
Now?
Yep. So,
all right. Let's, Mansi,
yes,
Mansi,
sure.
we'll come back to you in a few minutes.
Okay.
We just need to go to Horst first.
Okay.
Briefly.
All right.
Horst,
Okay.
can we link to Frankfurt?
Then I go straight to my
Horst? Yes, we can.
Sound.
Hello. Dah dilator tak? Hello?
Speaker here.
Tasha use dilator.
Hello, Kuala Lumpur. It's Alison Sabalka.
Okay. Alright. Hello.
Hello, who am I? It's Alison Sabalka.
Thank you. Hello. Hello.
Hello.
Hello. Is it Shaq there?
Hi, it's Allison Sabalka.
Coba.
Sarah.
Okay.
I am just the live center coordinator, so we are going to be transmitting now from
Right. Okay.
Frankfurt, and then we will come to you when they are finished deploying staff.
Okay.
Dah, masuk already. Masuk already.
So you have ASD closure?
Just a
Yes.
technical
Yes.
question, and that is, Masni's Kuala Lumpur link satellite time is limited, and so they're just hanging. I don't know whether we'll run out of time by the time we get back to them. Yeah, they're ready now. They're ready now. So we were going to. So can we do that and come back to you? Okay, let's relink to Kuala Lumpur. They're ready.
Yeah, we're ready.
So
I guess, are you ready?
all right. Hasri,
Yes, Shaq.
Yep.
Can you hear us, Shaq?
I can see you and hear you. We've got limited time, I understand, from the satellite side. So if you could tell us what you're doing.
Can I have the mic, the speaker a bit louder, please?
You can't hear. Speak a bit louder, please. I cannot hear.
Sorry, Shaq. We could not hear you clearly.
Yes. Isham told me you have limited satellite time. And so what we wanted to do was, if you tell us what case you're doing and then proceed.
Summary, case
Yeah.
summary.
Okay. I think I would like to introduce
team.
this case. Dr. Ali shall present the
History.
case for today. Ali, please.
Hello, good afternoon, everybody. I would like to present our live case quickly. She's a 65 years old lady, presented with palpitation and progressive effort intolerance for past 4 months. She's NIHA class 3, and she had a cardiac assessment revealed atrial fibrillation with moderate size secondum atrial septal defect. She had systemic hypertension, which well controlled under amlodipine, and she had a multinodular goiter. Currently, she is a normal thyroid function on carbimazole. She was planned for the thyroidectomy by the referring hospital. She's non-diabetic, she's not smoker, and she doesn't have history of ischemic heart disease. On examination, when she presented to us, she was saturating at 95%, and blood pressure was 124/88 millimeter mercury. She had regular pulses with 80 beats per minute. She had mild edema and split second heart sound, no cardiac murmurs. ECG shows atrial fibrillations. ECG, the X-ray shows cardiomegaly with the pleuritic lungs. And this is the functional hemodynamic assessment. She had echo, which shows dilated right atrium, right ventricle with moderate TR, pressure gradient of 56 millimeter mercury, moderate size AST, 25 millimeter with left to right shunt. Estimated QB/QS from echo is around 3:1. And she had good LV function of 56% ejection fraction and no thrombus shown. The coronary angiogram was normal. She underwent a cardiac catheterization, which shows a mild to moderate pulmonary hypertension, where her aortic pressure was 151/84, mean of 109, and she had versus pulmonary pressure of 62/18 and mean of 35. She had LV pressures of 150, EDB of 8, and QB of 2:1. QB to QS is 2:1. And she has pulmonary vascular resistance index to her body surface area 4.8 Woods unit. And cardiac index was 2.7 liter per minute per square meter. So she had a left atrial appendage occlusion on 19 of June 2019 using a 21 millimeter Watchman device. And in brief, she's 65 years old lady with the secondum atrial septal defect and large left to right shunt complicated by atrial fibrillation and pulmonary hypertension. She underwent successful LA appendage occlusion. Intended procedure for today is balloon sizing using a LifeTech balloon and fenestrated ASD occlusion using a Sierra ASD fenestrated device by LifeTech. Thank you.
Okay. Right, Patrick.
Yeah, thank you. Shaq, I think with me, Leong Minchan, Dr. Gita, and Haifa over the other side. I think we go straight to Haifa because we had image transesophageal echo by Haifa. Can you
Yeah.
tell us
Hi,
something,
Shaq. Can you
Haifa?
hear me, Shaq? Hello. Can you hear me, Shaq?
Oh, yes. Good evening.
Okay. Can you hear me now?
Yes, yes.
All right, okay. So I'm going to go very quickly on the transesophageal echo, and you can see that there's a four-chamber view, there's a dilated RA and a RV, there's a trivial MR, moderate tricuspid regurgitation, and on the 0 degree, you can see that there's a moderate size ASD, which measuring about 22 millimeter. On the short axis view, you can see there's the very short anterior rim, small pericardial effusion. The measurement there is about 23 millimeter, and on the 60 degrees, the measurement is about almost the same, like 22 millimeter. Along axis view, you can see that the maximum diameter there is about 17 millimeter, but you have got enough rim. But you can see that the posterior inferior rim is very thin. So this is a very thin, it's an oval shaped ASD. Secundum measuring about about 17 millimeter, and a very short anterior, but the rest are all right. Primary veins are normal, and you can see shortly that that is where the Watchman device was, and it is quite stable. Primary veins are normal, and I think that's about it. And you can see here that on the 3D echo, the oval shaped ASD.
Thank you, Haifa. We did repeat the cardiac catheterizations a while ago, and yes, sorry, Sheikh.
Can we ask John Thompson here on the panel? So, if I'm correct, this is the left to right shunt, 3-to-1 left to right shunt.
Yes.
Dilated right heart.
Yeah.
You're planning to use a fenestrated occluder?
Yeah, I think we aware about this, but the issue here, we do suspect the left ventricle is perhaps stiff or maybe restrictive, especially in this group of patient. And on echo just now, we can appreciate the left atrium is dilated. Left ventricle is perhaps on the smaller side by eyeballing, I would say, even though it's not accurate. But if you look at our hemodynamic data, yes, Sheikh, sorry.
Hang on. Can we put this up to our audience to see what people think about your proposal? So, we have hands up for those that would propose this with an ordinary device.
See that?
They close with a normal device before.
Yeah.
They want to ask the opinion from the floor.
Okay.
Looks like 50-50.
Yeah. I give you some information. We did repeat the cath. The hemodynamic shows that shunt is about 1.8, probably about the same as the previous one during the LA occluder. The LVEDP is about 10 without the balloon occlusions. When we did the balloon occlusions, the LVEDP goes up about 14. I'm not sure how significant it is, but I think we have to try to mimic once if we completely close off ASD.
Let me ask Larry, because you said with balloon occlusion it equals 14.
Yes, yes.
24.
I am in favor of fenestrated device, not because the LVEP goes from 10 to 14, so that's very minimal increase. I don't think that's going to affect in any way the left ventricle function, and even if it deserves just works a little bit to be better within 24 hours. I'm in favor because you said the patient has the history of atrial fibrillation, and in the future, if you have to access the left atrium, you have a fenestration, it's not easier than to go around patient to patient.
Okay, that's...
Okay. You just press the button. What do you think about the
I agree with you, Steve. So what I would do with this patient, I would accept it in the with the ASD balloon occluded. If the PA pressure drops, the TPR is less than 3 pulse units, I would close it completely. The EDP does not increase up to 14 if you want.
Okay.
Correct? Yeah. Sometimes there can be a discrepancy between the balloon occlusion hemodynamics and device occlusion hemodynamics. As a matter of fact, balloon occlusion will get to increase the EDP a little more that device computer because of the phenomena of moving. So if when marginal increase in PDP of 4 millimeters, I'm not convinced that I will go ahead and do the penetration class. It's just a concept that these points, actually, the penetration 48 says, this is ablation 48 says, at least 70-80%. Brain control is nowadays better than ablation. Yeah. Okay. Also, we have to keep in mind that there are more and more cases we see that we have to go on the device to operate. So if there is a questionable case, this appears to be absolutely no harm with the mechanism. Okay. All right. Let's keep you moving then.
Thank you very much for all those input. I think then what you do, we have to, I give you the PVR is 4.7, the PA mean pressure is about less than 50% of systemic, 40 against 100. QPQ is 1.8, yeah. But I think when we did the balloon stop flow technique by echo, the size is about 23, 24. I would like to show you the corresponding measurement by fluoroscopy once we, can you show the balloon here? Which is about 22. So now we are thinking of the size, choice of the size of the device to use. I need some comment or suggestions from the audience there.
Okay, so the weight is 22. Sorry,
yes, 22 by balloon and 24 by echo.
Stop flow.
Stop flow technique.
It would, if it's Doppler or the stretch.
Again, sorry?
I would use, you look like you've got a wear for setting 22. So that's 222, John?
Yeah, 22 by balloon, fluoro, the same measurement by transesophageal echo is 24.
24. Okay, 24, 224, 222. From the audience, show of hands, those who would use 22. 1. 24.
Okay.
Oh, right. 26.
Okay, good.
Okay. So the majority
Want to show
are
the
going
device?
to 24.
The connection easy.
Well,
22.
Before.
Don't tell me 30.
okay, Shaq.
Patrick, what are you going to use?
I decided to use 26. I think I'm take some consideration of a bit of floppiness of the septum. But I understand do not overstretch over too much. But I want to show you with regard to this device. Yeah, this is the device.
Patrick, if you have such a strong weight, why are you oversizing it so much? I'm pretty confused after 40 plus years of ASC.
Zahid,
very good space. You measured 22 and you're going to 26. Why?
Well, I can understand your concern, Zahid, but I think the fluoro echo 22 by stop flow technique, HIFA show it 24. Well, you can use 24, but I don't want I need some assurance a little bit. By 26, I don't think that much overstretch, yeah. I hope, I know 28 is too much, 30 is no. 26 I think is not too bad.
Okay. Carry on.
So, just to show you this device, that's 26. At the middle, at the 12 o'clock here, you can see the fenestrations. The size is up to 28 is 5.6. Yeah, 5.6 because it's a bit of oval because to consider the metals over here. The shape is about 5 and 6. Anything more than 28, 30 and above, the size of fenestration is 7 and 8. Yeah.
So what size is the fenestration, sir?
This is 5.6. 5
okay.
mm by 6 mm. Okay.
I'm still telling you, you said this patient has a history of atrial fibrillation, and now you're going to put a more oversized device and you're going to subject it into more arrhythmia. Seriously, I mean, I think it's, I know you can use 26 here, but for the data body, you really don't have to oversize. No, please don't. Point taken, but carry on, Patrick.
Okay, thank you.
Okay. Speech first, Dr. Haji, at the clock.
would just
Okay, I want, because I think this is quite some time inside, I make sure there's no thrombus inside. The air. Give me the bigger
Syringe.
syringe.
So what for this zero device of 26 millimeter diameter? What size sheet are you using?
Sheath. What size?
Yeah, what size sheet?
This is
14 French.
26 can go to 12, but I use 14.
Okay. Oversized.
Because
Good.
initially I did not know whether I'm to 26 or more than that. 28 in it, 14.
Yeah. I think you were probably thinking of 28 originally.
Okay, we go live. I think the tenor is the same as like usual. Here's the closure. Generally, I use the right upper pulmonary vein for the across, but in this case, I think it's okay. Oops, too much. The most important thing is that we would like to see how does the left ventricular and diastolic pressure.
See the TOE as well.
Can a TOE please, Haifa?
Yeah. I think you can see
Can you
that
see that
the
TOE?
LA disc is coming out.
Not yet.
Okay. Can we have the EE?
Yeah, but we want to see both.
Okay.
Picture thing.
Okay, I think open up a bit more ways over here. I think this is quite good position to release the.
Okay, we want to see picture, so fluoro and
Okay,
TOE.
capture.
Okay, never mind.
Oh, you put the color. I think it's slanting.
Slanting.
Is this something? Yeah.
Yeah.
I don't think this is in good position. I think the
You
the
can
right
see
disc
that-
is on the left side.
Yeah, both these are on the left
Okay,
side.
this is not a problem. Now get a picture in picture.
Right about that.
Okay. Are we okay, Haifa? Yeah.
Yeah.
So take your time, Patrick.
Okay.
Looks better.
Technician secure fluoro as well.
Yeah.
So you can
Okay.
do that.
That
Yeah.
looks
Now?
that looks
Yeah.
better.
I think we focus on TOE, please. I think this is more pretty clear to look at the septums. It's sandwiched in between the both the left and right discs of the device.
Okay. Hyper
okay?
short color will flow through the penetration too.
Okay, this is a long axis. I think it's probably too deep.
I
Okay,
think it's okay, huh?
that looks not too bad. You can see at the posterior end there, can you off the color because I need to go to 0 first.
I don't think this is too much oversized, Zahid.
So
what do
you
you think? Looks flattened to
So
me.
this one looks good. This one looks good. Okay, and that looks good too.
To the penetration.
Again,
Show
sorry.
the fenestration, please.
I think that is.
I think it's best if we, if everyone's happy, you can completely release. Then can the device is repositioned nicely. Then Haifa can demonstrate the fenestration well. Yeah.
Yeah, the
Are you
release-
happy with the positions? Any objections to not to release?
Good.
It looks good. Yeah.
Zahid.
If Hyper is happy, we're happy.
Okay. I am at the moment.
Okay. Release. Okay. Gita.
At the moment.
Okay. Okay. That's completely released.
Okay.
Okay,
All
Haifa,
right, that
can you
looks
show
good,
us the
position.
fenestrations?
Okay. Let's try and see where the penetration
Show
is.
the LVDP.
Because this is the first time I'm actually seeing this device.
So
So
Patrick, whilst
that looks
Hyper
like-
is looking for
Minta dia show
penetration,
the
what's the
picture.
VDP?
Minta
okay, that looks where it is.
switch. Okay.
The
Yeah.
LV EDV is 12.
And there's another shunt at the anterior end, which I think is probably just below the device. But the fenestration is actually at your posterior end there. I think that's the fenestration. Yeah. There. Okay.
Okay, that's very nice.
All right. So can we just probably look at the right ventricle?
Yeah.
Okay. That looks very good, Humphrey.
Yeah,
Humphrey, perhaps you can come back and present the residual whole next year and next year's meeting.
Well, how much time that we have, Sheikh? You want to discuss more on this?
But I think we've got Frankfurt waiting for a case as well.
Say that again?
That's good, that's good.
Kita buat
Yeah.
stop.
Yeah.
Put the curve
Okay,
measure.
I think do you have anything else to say about procedure or anything?
Well, I think technical-wise the implant is similar, but I think to make a decision whether it needed to use fenestrated device or not, I think this is an area of debate and what kind of patient, especially in adults, those that has restrictive left or right ventricle and those borderline primary hypertension. Yeah, I think time will tell. When we do more and more cases and follow up, then we may be able to know better which patient that will benefit this kind of device, fenestration. Yeah?
There is another positive way of looking at this, Humphrey, which is if you were to use the 5 to 6 millimeter penetration in a 24 millimeter device, in relation to the surface area, it's bigger than a 5 to 6 millimeter and a 26 millimeter device. So you've satisfied all the sides.
Yeah.
Well, what is going to be the anticoagulation, antiplatelet protocol?
Well, in this,
raw material there and presence of atrial fibrillation.
well, this patient is atrial fibrillation. Of course, this is go to all this pathway of anticoagulations. The LA occluder is LF appendage occlusion is perhaps to reduce the risk of embolism. And I think for those that in sinus rhythm, I perhaps I may use the warfarin, but I tend to probably just aspirin will do. Yeah, but otherwise, AF is always NOAC is probably the best option. I don't have the answer which one is good, but I think any anticoagulation is a must in this group of patients.
Agree.
Yep.
Thank you very much indeed. That was a very stimulating case. So thank your team as well. Well done.
Yeah, I think before we end, we'd like to thank you, Sheikh, again, and also all the staff that involved in this cath lab, and then the LifeTech that give the opportunity to make this happen. The last thing is the CSI team in Frankfurt, especially Horst Sievert, and lastly, perhaps the TV3 Malaysia that make this thing happen. Thank you, Sheikh, again. Hope to see you again some other time.
Thank you.
Okay, thank you. Thank you very much. We'll move on to CBT Frankfurt. Horst, we see you. Okay, we'll go back to Kuala Lumpur then.